Good morning, and thank you for being here, and thanks to Naveen and the rest of the team for the invite, for coming here to talk to you. I go by Nix, and I'm from UT Houston, and my topic for this morning is going to be talking about shoulder trauma dominantly, and maybe touch upon a little bit about chest trauma as well. My interest is to share some of our clinical engagement of what we do in our center, and I also wanted to show some of the stuff that I learned during my orthopedic residency days as well. So let's go from there and have a look. I don't have any relevant financial disclosures. I want to acknowledge some stalwarts and people who've taught me over the years, and Clark West, Tony Wilson, and Fred Mann have contributed a lot towards this. Nicholas Beckman is my colleague who gave me a couple of cases, and Chirag is some of the illustrations. I want to thank these guys. The primary objective is to look at subtle shoulder injuries. Think about what do we understand about the common ones that come in the ER setting? What about peri-shoulder injuries? How do we deal with that? Hopefully we'll increase diagnostic yield. Think about start from the basics is what we're going to do, and understand the clinical implications, and I'm going to try and focus a little bit more on that as much as I can. Talk to you about how it looks like from a surgical perspective, or what these guys are looking for, and how does that work in your day-to-day life. The basic outline is going to be, we're going to start with some radiography. We're going to talk about that. So we're going to really start from the basics, and then go and talk about dislocations, AC joint, scapular fractures, coracoid fracture, and then eventually finish up with a couple of shoulder-based things or chest-based stuff, scapulothoracic and sternoclavicular. So when you think about radiographs, I hope you're doing more than a couple of views. A typical two-view shoulder of internal-external rotation view in a trauma setting is just not acceptable. And those of you guys do expert witnesses, that just doesn't cut it. So you have to have an orthogonal projection. That's the way you want to look at it. So let's take a look at these. So when you take an AP view, here's a patient in the middle, and a generator, receiver at the end, and you end up with one of these views. And so here's your shoulder coming in between. And you get a glenoid fossa, which is oval in shape, and then you get an overlap of the humeral head. All of us know that. And this is what it looks like on an AP view. So what you're trying to find out is, where is the anterior margin of the glenoid? Where's my posterior margin of the glenoid? What happens to the overlap that happens around here? Typically, if you're looking at measurements, you're looking at that distance is going to be approximately, well, I don't see my pointer. Here we are. So that distance is going to be approximately about 6 millimeters of overlap is what you get on that, so if you're looking for that. So the space between the two is typically because of cartilaginous space, gives you an assessment of what's happening to the cartilage. It's useful for that. If you turn the patient about 45 degrees and get one of these Grashy views, you get that kind of picture. You get the glenoid fossa en face, and you also get a humeral head right across there. And the space between the two is obviously cartilage again, giving you an idea what the cartilage is doing at that point. Here's a Grashy projection. So watch out for the space between the two, gives you an idea about what the cartilaginous space is. And if you end up doing one of these views, which is a Y view, now you have a PA projection, patient coming across in between, and then you end up with one of these views. So you're looking at the coracoid process. The first thing, coracoid is very useful in cross-sectional imaging, so if you ever want to feel your own shoulders, that little annoying feeling that you push between your, right medial to your humeral head is your coracoid process. That gives you the first landmark. And then certainly the scapular spine and the body of the scapula. Together, all of these together form the Y shape of what you want it to be. And then there's your glenoid around there, and gives you an orientation of what's happening to the humeral head. Gives you an idea what kind of dislocation are you talking about. Where does it move? What does it happen? What goes on? I want to take a few seconds to make a plug for this view, the axillary projection. So if you really think about it, if you have a patient coming into the ER with one of the shoulder pain, getting them to do a complete 90-degree abduction is going to be absolutely painful. They're not going to be happy with what's going on. But I learned from Joe Martinez, who's a guy who's been in an ER 20 years ago, you don't have to do that. You can pretty much just get your arm abducted a little bit, and that's good enough to get your axillary view. A quick second to tell you about why axillary view is popular. If you're a surgeon and you operate on this, two common positions of the shoulder is what's called the beach chair position, which is where your arm is abducted and you're held across that way, or the second position in the OR is going to be a lateral projection, where you're going from the front to back. So pretty much all your portal entry is going to be anterior and posterior entry. So if you're a surgeon looking at imaging, in an OR, you got one of these pictures up in your board looking at it. So that's the reason why we need to know about it. So when you look at the axillary projection, it gives you a couple more details. So here's glenoid, here's humeral head, and there's your coracoid again, and there is the AC joint. So here's one projection where the AC joint, it gives you a great idea what's happening to the acromioclavicular joint, and we're going to see why that's relevant in particularly the AC joint dislocation situation. Another little warning about this, the little Mount Fujiyama across here is going to be the lesser tuberosity. I know this comes in every time, this is particularly for the trainees in the room. So that's where your subscapularis attaches, a little avulsion. That is a lesser tuberosity. It's not the greater tuberosity. So any pathology that goes along with it, watch out for that. So when you talk about dislocations, enough of normal anatomy, so move across into it. So dislocations, we have anterior shoulder dislocation dominating the picture. So you're going to most of the time, you're going to be right if you think about anterior dislocation. That includes the anterior inferior dislocation, which is luxator erector, and then the posterior dislocation is a much smaller component. Then we have other dislocations. Let's take a look at this. 32-year-old female patient with a fall. So that's a no-brainer. You don't have to do that, right? So when you think about a clinical setting, when you're looking at these patients, they are almost always holding their elbow onto the other side. And when you look at them, they lose the deltoid contour, which is what we're seeing here too. You can see it on this, where you see the deltoid contour being flat. So it's not a diagnostic conundrum to think about if you actually think and say, is this patient got an anterior dislocation? You can see the head of the humerus. So what can we say? We can talk about what's the position of it. In this case, a subcoracoid location. Here we are. And then you can see it on the lateral view, the scapular Y view as well. You need an orthogonal projection to be correct. So you can see where the humeral head is sitting out there. That's not the reason why we need the radiographs, right? The main reason why we need the radiographs is for this component, the post-reduction view. So if you're ever going to spend any time on an anterior shoulder dislocation looking at these imaging, I would implore you to try and take a few seconds to look at the post-reduction view. That's the main thing. What we're trying to find out is whether the congruity of its back, is it back in location? Does it look better? And you want to get at least a couple of views to make sure that it does. That's basically what you're looking for. What about this one here? A typical cyclist injury, falling across, and you get an obvious dislocation, but now this time you have a greater tuberosity fracture along with it. The challenge with these, you can see another projection of the same thing. The challenge with these is about the post-reduction view, is to see the adequacy of how close your greater tuberosity is sitting in. Again, two schools of thought. A lot of guys would let you go with that. You don't have to do anything. We're getting into a patient population where when you have the younger population, I'm talking about sub-30s, if they have a dislocation, it's almost mandated now, at least in our center, we get an internal fixation of these in addition to the reduction. So what you're looking for in these is to look at how close is the fragment, is it back in alignment, and you also want to see those tiny little fragments that's floating around. This is useful information to say, yes, I've got multiple intraarticular bodies sitting across there, so this ends up with a CT in our place almost all the time. So here's what happens with your scapular Y projection. You get that as a glenoid, and there's your overlap with the humeral head telling you, yes, it's back in location. That's pretty good. A bike accident, a shoulder patient. Here's another one. Just a cursory examination may look like, maybe we don't have much going on, but then if you look closely, you start seeing these fragments. This is another thing that happens in the field as well, which is our ER guys, like the EMT guys tend to reduce the joints on the field. The easiest way to reduce a joint is to get them over, to hang the hand over. They, in fact, bring them that way in the ambulance as well. I've seen that a couple of times, where it actually just naturally falls back in. When you get a radiograph, the joint is not out, but you get to see one of these little fragments that's coming out from there. So you are dealing with a glenoid injury, and that's a bony Bankart component. Here we are, looking at another scapular Y. And you can see those little fragments of bones just sitting on the side tells you this is a bony Bankart injury. Why do we care? What's on it for us? The main thing to look for is the percentage of the main thing that I'll draw your attention to is to say 35% of these is only visible in the post-reduction view. So please go back and spend those little extra seconds on looking at the post-reduction view for looking at what happens to the bony Bankart component. Why do we need that? Because we want to get a little bit more detail of what's happening with the glenoid. Guess what? We end up with a CT scan. And I want to show you that these are subtle injuries as well. But one of the big things that I always get into trouble is when I miss out calling a Hill-Sachs lesion. So I tend to look for these as well. And as a shoulder surgeon, that's one of the highest questions you get asked all the time. Is there a Hill-Sachs lesion? And why do they ask the question? Because that tells you very clearly this ligament is compromised, the shoulder was definitely out, and you had an issue with it, and that's the reason why you're getting that. And what components are important about Hill-Sachs lesion? It's again, we know it's a posterior superior location. It's typically in the top 1.5 centimeters from from the top of the humeral head. And then I want you to try and think about it and say, can you characterize this in any way? Can you put a little number to it? And you're talking about what percentage of the articular surface are you involved? And this is typically a less than 20%, a small, all the way up to 40%. Why does that matter, and how is this important? The reason is because if it becomes 40% and beyond, any external rotation will engage your shoulder, and you kind of get stuck in that position. So that's not fun. And that's the reason why we need to know about this. So I've got a little CT just showing you this, and so we can, let's see if it'll let me stop this for a second. So what we're looking at here is trying to go down this and trying to figure out what are the different components. So you're looking at, oops, sorry, yeah. Sorry, I'm not able to stop this completely, so here we are. So what I'm trying to do is to try and figure out where is my Hill-Sachs lesion, how big is it? Can I give it a characteristic, characterize a number across this is basically what I'm looking at. And I'm looking at that, and then also trying to find out what percentage of the glenoid is involved at the same time. So this is a moderate-sized Hill-Sachs lesion. In other words, it's just about the 20% of the articular surface is what is involved, and I want to mention that. So I also want to focus on the glenoid. Here's a glenoid component that's there. So you get a fracture of the glenoid. And you understand it's a bony back-guard injury. And what's the relevance of this injury, and how do we characterize this even further? If you think about the glenoid itself, it's your anterior bony buffer, which prevents the humeral head from dislocating forward. And you want to know what percentage of it is being involved. A typical number, if you actually look in the literature, 20–25% of the articular margin being involved in a glenoid fracture makes it an unstable shoulder. So you end up having surgery to correct that. So how can we calculate this, or how can we even give an idea what happens with this? So I'm going to use a 3D model here just to give you an idea. And here we are looking at the humeral head being subtracted, looking at the glenoid on force. And that's an approximate idea of how big the glenoid is going to be. And you get another position of what component of the bony back-guard involves. Again, this gives you an idea of the articular surface involvement with it. So this means that there is going to be a surgical fixation to it. That's what you're looking at. This takes us across to the next level of complex of what we need to think about. I'm not going to go into great detail about it, but we're certainly going to touch upon this. The reason is, when you think about a shoulder dislocation, please think about it as a bipolar lesion. In other words, there is a glenoid component and there's a humeral component. So we're going to evaluate both. And this leads us to talk about what would be the glenoid tracking. Most of you guys will be familiar with it, but let's just quickly revise that. Here's a glenoid surface, and what we're looking at is the bony component that's broken off. That's a bony back-guard component. And if you want to think about a small diameter, if you want to measure that, that's going to be the small d. And then when you think about the large, when you put a full circle that goes around to the glenoid itself, you get a larger diameter. And that when you're trying to think about how much of glenoid is left for the humerus to articulate, you start realizing to calculate what's called the glenoid track. I'm not suggesting you jump in and do this all the time, but it gives you an idea. You think about the concept more than anything else. The 0.83 just means that 83% of the anterior medial margin of the glenoid is what is articulating with the humeral head. So you're trying to find out how much of glenoid is there left in that location for the humerus to slide in and out. Leads us to talk about what's called an on-track lesion. All it means is the fact that you have a humeral surface that's going to run on top of a glenoid that's broken down, and it's got a track on it. It's got a room in it for it to slide back and forth. So if you have a small Hill-Sachs lesion, or a tiny one that doesn't affect the glenoid from running over it, the humeral head from running over it, you have an on-track lesion. And these are less severe injuries. We don't have to worry about them. They're typically dealt with in a conservative way, so you don't have to have surgery, and the humeral head is still sitting on the glenoid. The defect in the Hill-Sachs lesion is much smaller than what the glenoid articular surface is, so you don't have to have a problem with it. But if you go and look at an off-track lesion or a large Hill-Sachs deformity, so if you pause for a second, what we're talking about is, yes, there's a glenoid injury. When you look at the Hill-Sachs itself, there's a massive humeral defect across there. So with rotation, you're going to have an engaging lesion. That's basically all we're trying to talk about. So keep it simple. So you're talking about one of these, and that leads to what's called an off-track lesion, or the lesion where the humeral head subluxes and gets engaged. This is a surgical lesion, so watch out for this. And certainly, it's a more severe injury that goes along with it. And you need to start thinking about what glenoid tracking is when you're thinking about this feature. And I just want to leave you with one concept to say that there are other lesions that are close enough that can become engaging lesions, and that is how you want to calculate. If you're looking at distance to dislocation, it's a little bit more in-depth topic, but the reason for talking about it here is to let you know that when you're thinking about a glenoid and a humeral lesion, you want to think about what is the articular surface of the glenoid, what is the articular surface of the humerus. That's basically the bottom line. So how do you treat these lesions, and what happens? When you find something like this, where this cantilevered screws in the anterior inferior glenoid, the first thing you want to think about did they try to reduce a fragment? And for a fragment in orthopedics, it's something that you can hold. It's something that you can put something through it. So you can put a little suture anchor through it or a screw through it. So it's not those tiny little pulverized bones. That is not a fragment from an orthopedic perspective. So watch out for that. You got these screws going across here. When you look at that, you will want to look at the profile of the screw to see what did they fix? Did they put an extra piece of bone or not? And so this is just a fragment fixation. That's how you reduce a cannulated screw. What about this scenario here? Patient with constant subluxation. This glenoid attrition here, so that there's nothing bony to support the humeral head, and that's the reason why the humeral head subluxes all the time. And you get something similar. You have a fixation in the anterior glenoid, but this time you have a little bony block. And this is going to be a lattice procedure, whereas you can see in this cartoon that they take a piece of bone and augment the front of the glenoid so that you don't have a dislocation. That's what you're looking at right here. So what do they want to know about anterior dislocation? Keep it simple. Please look at the post-reduction view. You're looking at the glenoid component of what's happening. Think about the humeral head as well. If you see a Hill-Sachs lesion, please mention it. What percentage of the articular surface is it involving? That'll be the basic thing to put in your report. If you really want to go down the glenoid tracking mechanism, we talked about that briefly as well. So think about it as a bipolar lesion. That's the main thing. And for all soft tissue injuries, it's important to talk about MRI at that point. What about posterior dislocation? Clinically and radiographically occult most of the time, so it's kind of standard of care to miss it, but please don't miss it. We'll try not to. Typical appearance, 23-year-old post-fall, you get, that doesn't look right, and that's good enough to have a start with that. A typical appearance of what would be a light bulb, and that tells you, yes, it's a posterior dislocation, and another orthogonal projection like a scapular Y view demonstrating very clearly why this is a posterior dislocation. Again, the important components is to look at post-reduction views as well. Here's another patient. So when you tease through this, you can see posterior margin of the glenoid, anterior margin of the glenoid. You get the humeral head, and then there's a flattening of the humeral head. And we know there's no geometric flattening of the humeral head, so this is not right, which tells you that lack of congruity between the two, telling you that we need to take a better view or take a closer look at this. And this is a trough fracture that we're dealing with. So this is definitely an indication of posterior dislocation. An axillary projection demonstrating that much easier over here. What you can see is an impact of posterior dislocation right across there, and that is, again, a trough fracture. Sorry, take that back. That's a trough fracture right there. This is probably the most important view that I want to show you in a posterior dislocation is these are radiographs that you're going to run into your outpatient setting. You're going to see this, and let's look at that for a little bit detail. So here's your anterior margin, here's your glenoid, and then there's your humeral head, but you get this little extra line there. And if you thought that was a lesser tuberosity, it is not. The reason is that's greater tuberosity right there. Lesser tuberosity is not very far, it's right here. So you don't have an extra line there. That tells you that you're dealing with a posterior dislocation or a trough fracture. And that is a trough sign. So be watch out for that. This is what the fracture looks like on an axillary projection. And you have a trough fracture coming across there. Another one about 21-year-old swimming accident. You get to see, again, fragmentation of bone tells you that you're dealing with a glenoid and a humeral component, so watch out for it. Again, when you get lines closer to the articular surface like this, that would tell you that you're again dealing with something like a trough fracture or trough sign, so be careful about it. Look out for an orthogonal projection, and there is your posterior dislocation right there. You can see that the humeral head is, this is the humeral head across here, and there's your glenoid, so there is definitely a posterior dislocation across here. A quick review to see what happens on an MRI gives you certainly more detail. You can see fragments across here, all those ones where there's an impacted injury on the side, where the humeral head is still impacted in the posterior margin of the glenoid. You can see multiple fragments in the intra-articular space as well, tearing off ligaments that tells you that this is not going to be easy to fix or to keep it stable. Please spend a few seconds on the T1 just to make sure that you get to assess the degree of bone injury, both in the glenoid surface as well as in the humeral surface as well. So watch out for that too. Just to give you a quick overview on this thing to say, if you miss subtle injuries and you end up wanting to know more, obviously MR is the answer. Here is a fragment across the posterior aspect, a posterior bony Bankart injury, along with a fracture right through the osteochondral margin, extending into the labrum as well. So you can see that's a bony reverse Bankart injury with labral tear. So when you think about posterior dislocations, what do they want to know from us? It's more about the bony components. They want to know how much of the bone is injured. In other words, how much the glenoid is injured, how much of the humeral head is injured, and that's basically what you're looking for. And think about ligamentous injury as you go through that. Rare dislocations, luxatia erecta. The interesting thing about luxator erector is the fact that this is a straightforward inferior dislocation. If you think about your shoulder itself, your functional aspect of your arm is actually in front of you. It's right there. So when you're reducing these things, you're trying to find out, can I reach my functional thing? Can I use my arm in the right way? That's basically what you're looking for. And the reason why this is important is because we're not working up here. We're not hanging across from trees anymore. So that's the reason why luxator erector is not so common. That's the most weakest part of your shoulder because there's no bony support. The main thing to remember is the fact that you are going to cause a capsular rent and injure all the components of soft tissue next to it. Think about residual brachial plexus injury. Watch out for that. Let's look at some rare ones. Here's an 83-year-old patient coming into the ER. The thing that draws your attention is obviously some gas across there. And then you look at this curvilinear density in the upper chest. So what is that? And you wonder, what could that be? And that is typically an intrathoracic fracture dislocation of the humeral head. So if you look at a CT, it makes it very eloquent. Here's your fragment sitting in there. There is all of that coming across. And just to confirm, yes, you are missing a humeral head from the fracture site. So if you ever miss a humeral head, you know where to look. Look in the intrathoracic location. That's where you're going to find it. We want to talk a little bit about acromioclavicular joint. Main thing to remember is the primary reason for evaluating the AC joint is to look at the corococlavicular ligament. It's all about the corococlavicular ligament. And here's a cartoon demonstrating the same. Here's a 3D volume rendered image, rather. And you're trying to connect the clavicle and the acromion, and you get these ligaments coming across between the two. You get the acromioclavicular ligament, and then certainly you get the acromiohumeral ligament, coracohumeral ligament, I'm sorry. And then you get the corococlavicular ligament, which is the main component here. And you have a trapezoid portion and a conoid portion of these ligaments. You can certainly see them in more detail in MRI. Those are the acromioclavicular. That's your conoid portion of the corococlavicular. And then there's your trapezoid portion of the corococlavicular. And that's your coracoacromial ligament as it comes to. So when you think about injuries, you're thinking about the AC ligaments, trying to evaluate the acromioclavicular joint so that you get to see what the corococlavicular ligaments are doing. And as you go through 1, 2, 3, and 4, there are obviously more stages beyond this, but this is clinically what is most relevant, so this is the most commonest injury. And the 4 is the one where you actually have an injury through the trapezius. Let's have a quick look at that. Grade 1 injuries, nothing much radiographically, just a little bit of dull aching pain. On an MR, if you do one, you get to see a sprain of the ligament or a high signal across the distal clavicle. Grade 2 injuries, sometimes you get a shift of these, and it's not completely clearing the bottom end of the distal acromion. If you get the arrow, you don't clear this, you can see the level between the two. And you get some widening as well, and symptoms along with it. These are all conservative ways of managing what happens to the acromioclavicular joint. The corococlavicular space is still preserved. In other words, that ligament is not injured. When you start moving into grade 3 injuries, that's when you start seeing the compromise of the corococlavicular ligament. If the AC joint space is more than 6 or 7 millimeters, but more importantly, if your corococlavicular space is more than about 14 millimeters, that's when you start worrying about the fact that you lost the integrity of the corococlavicular ligament. So watch out for that. Here's another case I want to show you. So here's what it is. When you look at the distal clavicle, it looks like it's drifting up a little. And then you do an oblique projection. You're still worried about it. The space doesn't look too bad. It looks normal. And then that's where your axillary projection comes to bail you out. Let's take a look. There's your distal clavicle. There is a landing zone where you would expect the distal clavicle to be in. But guess what? It's not there anymore. This is a grade 4 acromioclavicular injury. The biggest thing that's happening here is just tearing through the trapezius and getting engaged to the back, and that's the reason why we need to know about this. And this is another location where this is probably the only way you're going to diagnose it, so be careful. If you have a suspicion of a grade 4 injury, please ask for an axillary projection or at least an MRI. How do you treat it? Multiple means. Common ones that are getting into vogue more is about tightrope fixation. You have these little drill tunnels through which a little rope goes around, and that's your endo buttons, which is kind of keeping the two together. This is what it looks like, just like in this cartoon here. So if it fails, you're looking at the position of the endo button more than anything else. So if it actually floats away from the bone, tells you there's no longer tension in the tightrope, and that means that you have lost integrity across there. That's failure of fixation. So every time you think about the AC joint, please think about the corococlavicular ligament. That's basically what we're trying to say here. Let's want to spend a few more minutes on scapular fractures. It's a well-padded bone. So if you see a scapular fracture, you are dealing with the high energy violence. So spend a little bit more time looking at the chest and other things that can happen along with it. You see an injury such as this, you see a fracture, you want to see, is it going into the glenoid? That's the first question you're asking yourself. Next is to see if it is actually going into the neck of the infraglenoid neck or the supraglenoid notch. Is it going into any of those locations? Trying to find out what the extent of the fracture is. And so if you do that, again, Grashey projections can tell you about what the offset is happening in the glenoid. Here's what you can see on a radiograph. And certainly that's a scapular body fracture extending to the glenoid. CT obviously makes it much easier. And the intention is to see, is there a more than 2 millimeter step off the articular surface is what you're thinking about. And why 2 millimeters? Because a surgeon cannot fix anything that's less than 2 millimeters. He cannot make a difference. That's the reason why we're looking at that. Here's an extension. You get to see that there is a displacement of more than 2 millimeters in this case, telling you that this is going to be an injury that needs to be fixed. Look for associated injury that happens along with it as well. Look for where it goes along. So in this case, you see the fracture across the glenoid neck. You see the disruption of the acromioclavicular joint, widening of the clavicular space. And again, a scapular Y projection shows you that the base of the spine of the scapula is again fractured, extending all the way down. The base of the acromion is gone. So you are dealing with a severe injury. Leads us to talk about just basic zones of scapula. You don't have to know about Zarkovic and Zamzol zones, but it's important to realize what different locations these fractures are. Apophyseal fractures, not too bad. They can be treated conservatively. Body fractures very similar, except for the fact if they're tented, in other words, they're overriding, that's the only time you have to fix them. But this zone here, the superior lateral angle fracture, you have to watch out for these because of extension to the neurovascular bundle here and also to this location. Watch out for that. 3D demonstrates it much easier. You can see the extent of fractures. You can see this, and it's easy to show your clinical colleagues as well. Leads us to talk about a concept called floating shoulder. What are we talking about? We are talking about this ring of structures together, which is a combination of bony and ligamentous support, creating an integral component of strength, of load bearing that happens. So if you have a fracture that goes through that, you are dealing with the floating shoulder. So how do you do that? You look at where the fracture patterns are. Here's a glenoid neck fracture. And then the most important component is, do you have a fracture of the clavicle, yes or no? That's basically what you're looking at. That compromises the entire component of the bony attachment, ligamentous attachment, and you're dealing with a floating shoulder. So if you're looking at it 3D, you look at the extent of the fractures, and then you see if there's a clavicle fracture, and that tells you that you are dealing with what would be a clavicle fracture going along with it. That'll become a floating shoulder. These require surgical fixation. Typically, it's a two-stage procedure. You tend to fix the scapula first and then go after the clavicle a little later. That's basically what you're looking at here. So what do they want to know? Is it articular involvement? Is it going through the glenoid? Is there a step off? Is it going through the supraglenoid notch, infraglenoid notch? Is it going through any of those components? Do you have a compromise of the clavicle fracture at the same time? That's basically what you're looking for. A quick review about coracoid process. When you think about coracoid process, you're thinking about where does the fracture happen? If it happens to the tip, that can be ignored. Usually you don't treat that with any surgical procedure. But once it starts compromising the genu and the foot margin here, then you're compromising the coracoclavicular ligament, and that needs to be fixed. A typical fracture that you can see, people presenting with pain and dull ache across there. Here's a fracture that's going through the root of the coracoid. Here's another example where you get to see much on an internal-external rotation view, but your axillary projection gives it away to see there is a coracoid tip fracture. Again, why do we care? Because the reason is the fracture affecting the base compromises the coracoclavicular ligament. So watch out for location. If it's going through the base, you've got to be careful about it. That's the reason why you need to know about it. The last couple of, maybe a minute or so, talking about scapulothoracic dissociation. This is something to raise your awareness about, so please do think about it. Muscle disruption, it's essentially a closed four-quarter amputation. In other words, this distraction forces that's taken apart portions of your shoulder from inside, which means that you're going to have muscle, vessel, and nerve damage as it goes through. Here's an example, 21-year-old MVC patient. The first thing you look at it is, wow, the right side of the shoulder is far away from the midline. This gives you an idea where the medial margin of the scapula is just distracted away all the way across from the midline. And there is your fractures that's going through the scapula as well, means that there's going to be extensive muscle and ligamentous injury as well. The distance from the midline is far away compared to what your normal side is. If you really want to measure, that's called the scapular index. If the ratio is more than 1.01, it tells you or draws your attention to say you're dealing with the problem. Here's another example. You can see the medial margin of the clavicle, epipleural hemorrhage on that side. Look closely and you'll see the fracture across on the side as well. This is something to be careful about. So again, the scapular index showing you that this is actually something to, it gives you an idea that there's internal damage as well. Typically, you need to end up with a loss of pulse on that side. Clinically, that's when they kind of call us and say there's asymmetric pulse. I've definitely missed at least one of these before, and they come back and find you to see what happens. End up with a conventional angiogram or a CT angiogram. Here's a conventional angiogram showing you a complete loss of shutdown of blood vessels across there, and that's what was done before. Here's another case. Let's look at this. You get to see the gas across there. You get to see that the widening of the scapula away from, or the moving of the scapula away from the midline margin tells you that there is your increased scapular index we talked about. And here's your shutdown of the vessel that happens. You have an axillary arterial shutdown, so watch out for these. These are devastating injuries. An MRI showing you that there is an associated brachial plexus injury as well. A last case to look at, sternoclavicular dislocation. This one is very, very tough, at least in my realm. And you got to concentrate and go back and look at these. And it gives you a widening of the clavicle from the sternum as such. And the reason why we are interested in this, because of the concentration of vessels and nerves right behind it. So any posterior dislocation or damage to that will lead to a vascular injury, such as in this case. That's what he's seeing right here. And also in another case here, you can see that there is widening of the clavicle, medial margin of the clavicle from the sternum as such, from the notch of the sternum. And when you look at the axial imaging through that, you can see damages that's going through with it. High velocity injuries resulting in sternal fracture as well. And this one here at the back is compromising, again, your vessel injury at that point. So high velocity trauma, it's thankfully rare. It's 0.6% of cases. So in summary, please look at your radiographs. Try to make sure that you have adequate number of them to give you orthogonal projections. Dislocations, watch out for bony component, glenoid, and the humeral component. Think about how much of room there is for the humerus to articulate. That's most important. Coracoclavicular ligament involvement in AC joint injuries. We're looking at the coracoclavicular as the main component there. Coracoid is going to be the base of the coracoid or the root of the coracoid injury. Scapular, it's all about that orange zone that we talked about where the neck of the scapula is going to be. And as far as scapulothoracic dissociation and sternoclavicular, just have to be careful that we need to have it in the back of our mind all the time so we can pick up these injuries. Thank you so much for your attention. Appreciate the time. Thank you. Don't know if we have time for questions or. Oh, I can hear you. I can repeat. Yeah.
So, the question I have for you is that it's very interesting what you said about the axillary view and that you don't have to actually lift the arm all the way up to get it, because, that's a big problem for us, because the techs feel very uncomfortable doing that, and it's always an issue because the orthopedic surgeon or resident wants that, and so one thing that we have kind of used is the Valpo view. I don't know if you're familiar with that, and that kind of gives you that same axillary view kind of radiographic image without, again, having to lift the arm. So that's something that we've kind of moved to, but it's very interesting what you said about essentially doing the axillary without necessarily lifting the arm. So maybe that'll work as well too. I wanted to get your thoughts on that.
Absolutely. No, thank you very much. The Valpo view is something that we use in our clinics all the time. And for the ER setting, I don't know why, but it's been gravitating by technologists who've been resulting in talking about how they can do the axillary projection. They've been doing a great job of what we are currently doing with the Valpo views. I agree with you. It's very valuable in the same concept. And it's more about the idea that it's the visualization from the surgical perspective as well. That's why it makes it easier as well. Thank you for bringing that up. I appreciate that.
Fantastic talk. Thank you so much. My question was about the on-track, off-track lesions. And I just wondered, how often do you actually measure any of that? Do you do that daily or just rarely? Give me an idea.
Thank you for that question again. So on-track, off-track lesion, we have, in our practice, we totally have around 11 shoulder surgeons, dedicated ones. And there are 2 of them who are absolutely painfully want us to do it all the time. Yeah. So, and there are arguments about it. There are times we bet beers on it. So that's the only useful reason to do it. But beyond that, I mean, so excluding those 2 guys, we do not talk about on-track, off-track. I would be curious from the audience as well if anybody else is putting it on a routine basis. Do you guys do that all the time?
Everybody raise your hand if you routinely measure on-track, off track. One person?
Okay. Thankfully not to you, Stuart.
Yeah, our surgeons have not either. We have a couple dedicated shoulder surgeons, and they don't ask that we do.
I'm glad to hear that as well because I don't like it, but so.
Yeah, thank you.
Thank
One
you.
other question, sorry.
Yes, please.
I just was curious, what happened to that patient with the humeral head in the chest? Like, what was the mechanism of injury there?
So it was a motorbike accident. He was a pillion rider on that, and he ended up hitting the phalanx, and that's what it is. And unfortunately, the question that people were asking, can you salvage the head? And the answer is no. So that's what happened to him. But yeah, thank you for asking the
It's a
question.
beautiful case. Thank you.
Thank you. Thanks again. Thank you again for the time. It's my pleasure to invite Vivek to come and give us a last talk of pediatric trauma. Thank you.